Hello, everyone, and welcome to What We Know and What We Don't Know about Gastrointestinal and Nutritional Care. My name is Jen Weber, and I'm an adult with CF. I will be moderating the session today, and we'll be introducing our other speakers in just a moment. Before I do, I want to provide a few logistics and reminders. This session is being recorded and will be available after the event on the CF Foundation YouTube channel. You will be notified by email when session recordings are available. We will be taking questions from the audience throughout this session and will answer them during the last 20 minutes of the session. We encourage you to submit your questions at any time in the chat box. We will not be able to answer questions about individual care and treatment plans, and we encourage you to use the information you learned today to have conversations with your care team. We may not be able to get to all the questions, but we will do our best to answer as many as possible. Before we begin, I want to remind everyone of our event contact guidelines available on the Foundation's website. Please be considerate, open-minded, and respectful. We ask that you do not use malicious or offensive speech and do not ask for or give medical advice. If at any time you feel the event conduct guidelines are not being followed, please contact the CF Foundation staff member at the help desk. Finally, if you experience any technical problems during the session, please visit the help desk in the expo area on the left-hand side of your screen. Now, let's get started. Thanks again for joining us today. I'm ready to introduce our first speaker. Steve?
Thank you. I appreciate this opportunity. And what we're going to talk about today, obviously, as a gastroenterologist, this is very cool, is our new frontier in gastrointestinal care in cystic fibrosis. Sorry, let me move forward with this. There we go. And on my next slide are my disclosures. I have no conflicts of interest other than I am on the scientific advisory board for Anagram, where we're working on a recombinant pancreatic enzyme preparation. And as you can see, I am funded from multiple sources, including National Institute of Health and the CF Foundation, and run a large translational research lab and oversee what's called Digest training program with my team at the CF Foundation, you'll hear more about. So there was a recent CF Foundation survey, this was last year, looking at what the key priorities are in CF care research and programs that we can offer, with a follow-up survey in February, where another 528 additional responses came in. And let me just share them right now. And what you can see here is that what's the number one issue that's most burdensome or a challenge for people with CF? It's digestive issues. A close second was managing and coordinating CF care. And if you now drill down on this, what are the research priorities? What you can see, no surprise, genetic therapies were very high on the list, but digestive complications and mental health and aging with CF are very close seconds here. And if you look at what are the main issues in GI that are most problematic: bloating, gas, diarrhea, loose stools, constipation, difficulty passing stools, and abdominal pain and reflux, poor appetite. So, not surprising that these are many of the issues that people with CF face, and we still are just barely moving the needle on these. And that's what I'm going to go through on our journey today here. I'll start off talking about what are the causes of GI symptoms in people with CF. How can we address these issues? You know, what are workforce development? What are medications and diet that may make a difference here? And Jessica Alvarez will then talk about diet and food and nutrition and how that can play an important role in people with CF and GI problems. I'll talk about CF and aging In some ways, it's an exciting time. We have these now highly effective CFTR modulators, and now a newer version of that has come out in the past several months from Vertex. But in some ways, this has now raised a number of other new issues as people with CF age. And how can we now think about these issues almost being geriatricians, specialists who deal with aging just in general? I'll talk about the increased risk of GI tract cancers in CF, why that is, who should we screen, when to screen, how to screen. And then lastly, how do we treat these GI cancers? Do they have a different biologic behavior? Are they more aggressive? Importantly, how we can prevent these GI cancers in CF. And we also need to just think about the anxiety that's associated with that and allaying that anxiety. So let me move forward now and let's talk about what causes the GI symptoms in CF. And knowing what causes them, we can now come up with rational treatment and rational strategies to help address these issues here. So, on this next slide, and I tried to do this by hand on my PowerPoint, so forgive my diagrams. I'm not the best artist in the world, but it highlights what are three underlying problems of how a defective CFTR gene, the CF gene product, affects the GI tract. The first, and I think most people are aware, that just like in the lungs, all the secretions are too thick in the setting of cystic fibrosis. And if you have thick secretions in the intestine, that's obviously going to impair digestion, absorption of nutrients, movement of things through. But that's only one part of the story. The second thing that investigations have shown is that the CFTR chloride channel is in all the nerves that regulate the movement of things called peristalsis through the GI tract. And this is only now beginning to be understood. There's very little research on this, but we do know that the CFTR chloride channel, if it's defective, all these nerves aren't functioning normally and regulating that normal movement, that peristalsis, starting in the esophagus, through the stomach, through the small intestine, through the colon. And that would explain a lot of the symptoms that people have. And then third is we have abnormal bacteria just in the like just similarly in the CF lungs that we have abnormal bacteria in the CF gut, the CF intestine. And if these bacteria are abnormal, then that can also affect motility of things moving through. It can lead to gas and bloating and other symptoms. So, if we now focus in on these three areas, it becomes clear why GI issues are such a problem. If you have thick secretions because of CF, you're not going to get nutrients through those thick secretions lining the intestine, and you're going to have malnutrition. It will also lead to things kind of plugging up the gut, just like the lungs. If they're not moving secretions up, they plug up your lungs and you end up coughing and you have mucus plugs. The same thing is happening in the GI gut, that these thick secretions, it leads to malnutrition, to constipation. And if the constipation becomes more and more severe, it may lead to blockages called DIOS, distal intestinal obstructive syndrome. So these thick secretions are a problem. As I said, that's one part of the equation. The second part is because the nerves aren't working well, and there's almost as many nerves to the GI tract as there are up in your brain. So these nerves play an important role in motility. And if they're not working, it's dysmotility. So what happens? The stomach becomes kind of paralyzed, gastroparesis, stomach paralysis. Doesn't empty well, you get full quickly. You may have things refluxing back up into your esophagus, and you feel the acid and everything coming up after a meal. You're full quickly. You may have nausea. If you have dysmotility, things aren't moving through the small intestine and through the colon normally, and you'll be constipated. And then there's the third component, the altered microbiome. So if you have abnormal bacteria, the bacteria love the nutrients you're taking in. It feeds these abnormal bacteria, and they produce a ton of gas as a byproduct, and you become bloated, gassy, distended. We call it SIBO, small intestinal bacterial overgrowth. It's a problem in just the general population, but especially a problem in people who have CF. And you develop, because of these abnormal bugs, this kind of leaky gut, and you're leaking potentially bacterial products into your bloodstream. And as a result, you have this kind of chronic inflammatory state. That also, these altered bugs, I'll talk about a little bit later, also increase your risk for certain kinds of cancers. So it's these three things that actually cause these persistent GI issues to be a problem here. And as we think about this, it actually starts to make it a little bit easier looking at this kind of model of three issues of let's attack these three things. Let's attack the thick secretions by giving certain medicines that thin things out. And this may be things like Marilax. This may be certain medications like Linzess. On the dysmotility side, we have motility agents that we use in people who don't have CF, such as metoclopramide or Reglan for gastroparesis, prucalopride, a more recent FDA approval for dysmotility that can also help in the setting of CF, turn on the nerves. And then the altered microbiome giving certain uh, antibiotics. And there's a whole different array of different ones we use, including one called rifaximin that's great for SIBO and minimally absorbed. So, what about treating these GI issues? I talked on the last slide a little bit about meds and things like that, but what about dedicated GI individuals who understand CF? And starting in 2014, the CF Foundation had the vision to develop a workforce of GI trained specialists who know about CF, training both pediatric and adult GI faculty initially across the US and then expanded to Canada, and now we're across the globe. This program's called Digest, and with Sarah Jane Schwartzenberg, a pediatric GI specialist in Minnesota, we head up our Digest program. It's a 3-year training program, and we're at quite a few sites across the US, but we're not at every site, and we've developed outreach programs for that. We train about 17 GI CF specialists every 3 years. And this group also develops best practices and also has developed and initiated a number of different research programs. Our first one was Galaxy. We had no great readouts for what would be a good outcome measure that would tell us if a drug or a nutritional approach or something that we're developing would improve a GI outcome. In the lungs, we have FEV1, but what about in the GI system? We didn't have anything. Galaxy has developed those outcome measures that are now used in our trials. We have Promise, which was looking at everyone for about a month before being put on Vertex's Trikafta when it was being first approved, and now following up to 6 years after being on Trikafta in the real world, looking at all organs and how CFTR modulators such as Trikafta were impacting organ function and development. Sarah Jane Schwartzenberg and I head up the GI aspect of this. And although, and you all probably know this, although Trikafta has been amazing for the most part for the lung disease in CF and the sinus disease, it has had little impact on the GI aspects of CF. And we also have strong CF. Jessica Alvarez, who's about to talk after me, is one of the leaders in that, looking at what are predictors of malnutrition in people with CF, and especially those with advanced lung disease. Can we predict way ahead of time markers that tell us that someone's going to develop malnutrition and intervene? We have nice CF. I'm going to talk a little bit about the increased risk of colorectal cancer in CF. It's screening colonoscopy. Can we come up with something that's a non-invasive predictor of finding polyps or cancer in our patients with CF? Nice CF is looking at a modified Cologuard and another test for that. We'll have some preliminary data NACFC. GRASP is looking at how do we define reflux symptoms in CF and develop therapies, and then developing a recombinant pancreatic enzyme. And there's now a couple of companies working on that, including Anagram. So next is CF and aging. The great news is we're having a major impact on the CF lung disease with drugs such as Trikafta. The downside is we now have a whole new landscape as our patients with CF age. So this new frontier, and with Amit Euler, it's going to talk later this evening, and others, we've developed a whole CF and aging fellowship program through CFRI. It's called the Patrick Nash Fellows Program. And we're trying to look at how this landscape is changing, including the nutritional landscape. It used to be everyone had to be on a super high fat diet, lots of calories, over 3,000 calories. Now we're seeing obesity, and now we need to retailor the diets to being more healthy. Healthy because we're seeing new challenges in cancer, cardiovascular disease as people with CF age, osteoporosis, menopause, complications of diabetes, pancreatitis, psychosocial issues. And we need to address this changing nutritional and mental health issues as everyone is aging, including things like sarcopenia. I'm now getting into my early 70s. I'm seeing sarcopenia, muscle wasting here. I don't have CF, but how do we deal with that? And studies like Strong CF are guiding that at this point. So next is I'm going to talk about the risk of GI tract cancers in CF and why that is and who we're going to screen here. And we know that there's an increased risk of colon and rectal cancers in CF. It's about 7-fold increased over the general population, 27-fold if you've been transplanted because of the immunosuppressive regimen. So why is that? We know that probably 4 factors drive that. It turns out that a normal functioning CF gene or CFTR chloride channel is an anti-oncogene, meaning it's an anti-cancer gene, helps prevent cancers. So if it's mutated and you have CF, you lose that anti-cancer effect of that gene. We have the abnormal bacteria in the gut. We know that that predisposes to cancer of the colon and rectum. The high saturated fats that people have been on traditionally in CF is a driver of colon cancer, as well as a chronic inflammatory state drives cancer development. It's not just colon cancer that's up, it's pancreatic cancer is at least 3 to 5-fold elevated in people with CF. Lung and breast cancers are up. HPV related cancers. So these are like anal cancers, head and neck cancers. They are also up here. And if you look at carriers, so parents of patients with CF and carriers of CF gene mutations in the general population, they're at an intermediate risk. No one is focused on this. My group is starting to spearhead that, but we know this is an issue as well. And if we lastly ask the question, so how should we be screening and treating for these cancers? My lab has been looking at this. We've now actually modeled this in a mouse, and there's an established mouse models. There's normal mice, and we can compare them to carrier mice, heterozygous, and to overt CF knockout mice. And if you just look, here's one example and work I'm doing with Deepak Panigrahi in our pathology group. In a wild type mouse, you inject them with pancreatic cancer, there's a certain growth after 30 days. And in a CF mouse, there's dramatic accelerated growth. So why do we care about that? What we're learning is that inflammation drives cancer. In these CF mice, this accelerated growth seems to be due to too much inflammation and a lack of these called resolvins that shut off inflammation. And we're doing the therapy trials right now in these mice, but it looks like simply dramatically increasing omega-3 fats, which generate these resolvins, or giving these specific resolvins. You can actually buy them from Amazon. Don't buy them yet. That seems to bring the risk down dramatically, even below what a normal mouse shows us with these cancers. So on this last slide, and this will be kind of the segue into what Jessica Alvarez is going to talk about. So this is just one example of what we're learning here. And this is about fatty acids and nutrition and CF and cancer. It turns out, and this is the work I've been doing for about 30 years, that the more severe the CF gene mutation is, the more altered these fatty acids are. These omega-3 fats, the more severe your CF mutation is, the lower these omega-3 fatty acids are, like DHA. This is what's in cold water fish that makes them so healthy. And arachidonic acid levels inversely go up in CF. And this is what's in things like red meats that are bad for you. They drive inflammation. So this combination shuts off resolvins, drives inflammation, drives cancer risk, at least in our animal models. And just this simple example is informing potential next steps that are relatively low hanging fruit. It's informing about nutrition. And Jessica will talk about how, for example, healthy fats have a lot of potentially important roles here in the healthy population, but also in CF, that it can change this ratio and it may decrease your risk of cancers and inflammation. It informs screening. We're gearing up and actually doing a study, part of the PROMISE trial. Does this ratio of DHA and arachidonic acid predict severity of CF, predict risk of cancer, predict how much inflammation is going on in your body? And then lastly, in our mouse model, we're looking at targeting this. If we reverse this ratio in a mouse model, does this decrease the risk of getting cancers? And then within 2 years, can we be in a trial in people with CF and also look whether or not that makes the difference? So I am going to stop there and let me turn it back over to Jen to introduce Jessica.
Thanks so much, Steve, for breaking that all down. As someone that's getting older with CF, the information around increased cancer risk is especially important to someone like me. I look forward to learning more about the colon cancer study and the clinical trials roundtable, which is during our next session of ResearchCon. And I'm committed to getting my colonoscopies early and often. Now I'm ready to have Jessica Alvarez share nutrition research update in CF.
Thank you, Jen. It is an absolute pleasure to be here to talk about some of the work that we've been doing, including Steve, surrounding nutrition in people with cystic fibrosis. So now let me just figure out how to advance my slide. There we go. Unlike Dr. Freeman, I only have one disclosure, and I do work with him for Anagram Therapeutics on pancreatic as a consultant for pancreatic development, but that will not be emphasized in this presentation today. Okay, so I hope you're hungry. I've designed my talk to be a menu. So I thought we would start with the appetizer, where we've been. I'm going to give you some historical context of how we've gotten to where we are now, main course, where we're going, the research that we're doing today, and then piggybacking off of Dr. Freeman, looking at healthy aging and where we're heading. That's our dessert. Okay, so I show this slide a lot. I love this slide. It just really emphasizes how much nutrition has always been important for people with CF. So preventing malnutrition it's always been a critical component of CF care. The combination of fat malabsorption plus the extra calories burned just from the energy, like breathing heavy, plus inadequate dietary intake can promote nutrient deficiencies. And these in turn can promote muscle loss, wasting, a weakened immune system that can contribute to recurring lung infection. And then you kind of enter in this vicious cycle, ultimately contributing to progressive lung failure. Then historically, we have seen, historical studies have shown that better nutrition in early life predicts improved survival and clinical outcomes. So in this study, using CF Foundation registry, patient registry data by Yen and colleagues, they looked at weight percentiles at children ages 4 years of old, born between 1989 and 92, and tracked survival at 18 years of age. And what they showed was those that had a higher weight percentile, so at 50th percentile or above, had much better survival outcomes compared to those with the lowest weight percentiles. And you guys have seen this before, I'm sure. You look at old graphs from the CF patient data reports. We constantly have seen this positive relationship between body mass index, BMI percentiles, and lung function. So as BMI goes up, so did lung function. And together, the knowledge of these historically nutrition recommendations were set for growth and BMI goals to achieve at least this 50th percentile for kids, BMIs of at least 22 and 23 for women and men. And to achieve these goals, we really put forth recommendations for unrestricted, high-calorie, high-fat diets. Of course, along with appropriate pancreatic enzyme supplementation, fat-soluble vitamins, and salt. So I'm going to refer to this unrestricted diet as our legacy diet, where the goal, and rightfully so, was just to make sure our patients, we got enough calories for growth, and to prevent wasting and further loss of lung function, as I showed you earlier. The thing was, oftentimes this translated to a no calories, a bad calorie approach, and scenario where we saw a high consumption of foods that we generally tried to limit in the general non-CF population. And to be perfectly transparent, these are all foods that I have off my phone because I've eaten them. So even the efforts paid off. Even before the widespread use of highly effective modulators, we were seeing improvements in nutrition status. So this is another CF patient registry analysis looking at trends from the year 2000 to about 2019. So again, before widespread FDA approval, or before widespread use of highly effective modulators. These blue circles represent the proportion of people with CF who were underweight. And we see that drop from about 15% in 2000 to 6% in the year 2019. On the other hand, we also started to see some trends, some increases in the prevalence of overweight and obesity. So this yellow dot represents those who were considered overweight based on BMI, and the gray is the obesity. And we do see those increases over the years in the prevalence of overweight and obesity. And so now we're dealing with a whole new landscape, as Dr. Freeman mentioned, of nutrition in people with CF. So flash forward to the 2023 patient registry report. We're down to 2% and 5% of pediatrics and adults who are underweight fantastic. But we've gone from 10% overweight obese in the pediatric CF population in 2003 to about 21% overweight or obese in the pediatric population. And then in the adults, from 18% overweight obese to 42% in the adult population. So we are starting to look more like the general population in BMI distributions. Of course, this is all based on use of BMI as our marker of nutrition status, but it's clear we are completely in a new era of nutrition for people with cystic fibrosis. So here we are, main course. Where are we going? What's happening now? So remember that graph that I showed you earlier, this really small right here, that kind of, we saw that normal line, that positive line between BMI and lung function. This is a graph that was taken plotted in 2022 from the patient registry. And you kind of start to see that linear relationship is starting to flatten out. That it's not as obvious that there's a positive relationship between lung function and BMI. So this sort of makes me wonder if BMI is really the right thing to focus on in this new era, because we're not seeing this trend. And so what's the deal with BMI? Well, BMI is great. We get it at the doctor's office all the time. It's a beautiful screening tool because all you need is height and weight. It's really great at identifying people at the lowest and highest extremes of malnutrition and obesity. But it's somehow become the target or the end goal of what defines nutrition status. And we know good nutrition is so much more than just height and weight, right? When we think about what makes up our body weight, it's both a combination of fat mass and lean mass, or you might hear me say it as fat-free mass. And even within that component of lean mass, we've got muscle, we've got bone, we have connective tissue, and we have organs. So you can kind of see how BMI can really miss this loss of lean mass, which are muscle, and bone, which is really most of what we focus on when we're thinking about longevity and health. So some of the work that I've done in my lab has actually looked at more than just BMI, really digging into body fat and lean mass. And so kind of highlighting some of the differences in body composition, we published a study some years ago showing we found an expected positive relationship between fat-free mass or muscle, lean mass, and lung function. You can see that here on the left-hand side. But unexpectedly, very surprising, we showed an inverse relationship. In this study, people with CF who had higher fat mass had lower lung function. So this was sort of a shocking thing to us, and again, just making us realize that we needed to be looking at more than just BMI. In this study, we also looked at something called normal weight obesity, which is defined as having a normal weight BMI, so BMI less than 25, but a disproportionately high percent body fat. And what we found, this is all participants with adults with cystic fibrosis. What we found was this normal weight obese group made up about a third of our little cohort. We also found that it was these folks with normal weight obesity that had the lowest lung function, and they also had the lowest lean mass, the lowest muscle compared to our other groups. So flash for a few years more, and this time we looked at using DEXA scans, which is considered our clinical gold standards. Again, looking at adults with CF and then comparing them to non-CF people without cystic fibrosis. And this time, we actually didn't show any differences between BMI, between our CF and our controls or non-CF controls. We also didn't find any differences between lean mass between the two groups or with fat mass. But look at this circle here. We did find that our adults with CF had higher visceral adipose tissue compared to our healthy controls. And so what's visceral adipose tissue? This is fat that it sort of it engulfs our it's within our abdominal region, and it sort of surrounds our internal organs. It is a very pro-inflammatory fat, and we want to minimize in CF, non-CF, the general population, this fat component. Why was that important in this specific population? Well, because not only was visceral fat higher, but it was positively associated with fasting glucose levels, which if you've done an oral glucose tolerance test, you know your doctors are always looking at fasting glucose. It was also people who had more visceral fat also had higher insulin resistance. And this is a component, at least, of type 2 diabetes. And we're starting to see that more in people with CF-related diabetes or at risk for CF-related diabetes. So these studies really, again, and I'm sorry to sound like a broken record, but this is kind of one of the main points that I want to take from all of this is that it really highlighted the need to shift from BMI and looking really deeper into the changes that are happening with body composition. And so Dr. Freeman queued me up perfectly. The CF Foundation caught on and gave us the Strong CF study, which is you probably heard about it. Well, you definitely heard about it from Dr. Freeman, but and other sites. This is a multi-site longitudinal cohort study aimed at finding the best measures of nutrition status in adults with CF, so that later we can figure out exactly where we need to intervene. Our goal is to recruit 300 adults with cystic fibrosis, and we are using a wide range of nutrition assessment tools to dig deep and better characterize nutrition. And we actually have we got our first little bit of results from a smaller cohort within our Strong CF study. This is hot off the press, an abstract that was submitted to the North American CF Conference for this year, where we looked at adults with lung function higher than 60% for FEV1%. And compared to the general US population, we found that these adults with CF had reduced muscle mass and reduced bone density. So again, really pointing out that this need to focus on body composition in adults with CF and children too, it's completely relevant. So what about diet quality? I'm a dietitian. I love food. And it's something that we need to talk about, especially given some of the things that Dr. Freeman talked about. So one of our studies, we used 3-day food records. So we have everyone record what they eat for 3 days. And we compared measures of diet quality, again, in adults with CF and non-CF controls. And what we found was that our cohort of adults with CF reported consuming higher added sugar intake, lower dietary fiber, higher saturated fat, higher trans fatty acid, and overall had a lower healthy eating index, which is a measure of diet quality, compared to our controls. And to tie it back with visceral fat, we actually found that among our adults with CF, those who consumed higher added sugar intake had higher visceral adipose tissue, which, to remind you, we had found earlier that it was associated with fasting glucose levels. Looking a little bit more at some of these, how diet quality was associated with glucose tolerance, we have actually shown, again, added sugars associated with worse insulin resistance, but also thinking about what Dr. Freeman mentioned, we've actually found positive relationships, so good relationships of monounsaturated fats, so these healthy fats, with measures of insulin secretion, as well as, this is something that I'd love to continue digging further, a positive relationship with plant protein and insulin secretion. Again, this is among adults with cystic fibrosis. So clearly an increased focus, again, the second main point for this talk is that we really need to increase focus on diet quality. Less so how much you eat, but what types of food are we eating? So I do think the shift in a focus on diet quality is catching on. So I had the pleasure of working with the Academy of Nutrition and Dietetics to kind of review some CF nutrition guidelines for registered dietitians. And for the first time, we explicitly recommended that people with CF consume a healthy diet that is consistent with positive health outcomes in the general population. We recommended consumption of nutrient-dense foods, including healthy fats and micronutrients. And then for people with CF-related diabetes, we recommended limiting high added sugar foods and beverages. However, you'll see the circle here. Our recommendations could only be assigned as a level of consensus. Like, we strongly believe as nutrition professionals that this is how you should eat. But it only got a grade of consensus because there truly was not enough clinical trials in nutrition to be able to definitively say, yes, this is how we should be eating. So this really highlighted the need for more research in this area. And so one of the studies in my lab sort of kept going with this story about added sugar intake that I was talking to you about. And so this is a study that we're doing at Emory. I'm in Atlanta at Emory University, called Feed CF, where we're randomizing adults with CF to a low added sugar diet versus a standard CF diet for 8 weeks with all foods provided. And the end goal is to see if there are any changes in diabetes risk factors, so looking at fasting glucose, insulin resistance, or in visceral fat, again, that fat that surrounds the organs. So recruitment's ongoing. I'm happy to answer any questions about that study. Okay, and now for dessert, our favorite. So where are we headed? So as Dr. Freeman mentioned, we really need to think about healthy aging in our CF population. Why? Because now 60% of our CF population is over the age of 18, which is just wonderful. We have the privilege of watching our CF population get older. And the privilege of dealing with these issues of aging that we could only just imagine before. So with aging, we're, CF or no CF, we're going to continue to see increasing prevalence of adults' diseases such as cancer, diabetes, bone disease, maybe even heart disease. So our thinking of how to manage long-term CF care really needs a major overhaul, and diet is a very important part of that. We're kind of in this out of the frying pan and into the oven situation where, we've had these life-saving therapies in people with CF, these amazing life-extending therapies. But now we're aging with chronic disease. And worse than that, though, is that we're aging in an environment that promotes obesity across the board for the general U.S. population. We're in a very obesogenic environment here. So we really need more research to better define optimal nutrition status for health and longevity in people with CF in this obesogenic environment that we're living in. Okay, so I promised some key takeaways. So this is some to-go mental nuggets for you on where you should kind of focus your energy. First, acknowledge and know that nutrient needs are individual. So I've talked about the increase in overweight, but that doesn't mean that there is no undernutrition and that's no longer a problem. It is a problem. There's just a much larger range of the needs of the general CF population, from malnutrition to overnutrition. That said, there are some areas that we can all focus on, especially as we think about our ultimate goal of creating healthy habits that can carry long into adulthood. First one, focus on overall diet quality. And something, just a takeaway, tip that I like to think here is, how can I add nutrition versus what do I need to take out? I love the focus on just adding things that are good for you versus like being restrictive and eliminating diets. Also, we don't really talk about, I haven't mentioned exercise or nutrition or strength training here, but really focusing on building muscle and being active is another one that I believe research will, and strong CF will help us there to, research will take us there. For parents of small children, adolescents, even adults in college, young adults, really modeling healthy eating and lifestyle patterns for all, making sure we at least introduce veggies early and consistently. I get it. I have an 8-year-old who might eat one pea every 3 days, but I just keep putting it on his plate. And one day, some days, I just watch him eat it, and it's amazing. Making healthy foods accessible at home. These are all ways to sort of help to create healthy habits of diet quality. With kids, it's not going to happen overnight. They're not going to just all of a sudden start eating broccoli. But you can be persistent, and over time, eventually they will. And this is another one, just sort of a pet peeve of mine, is when I see social media influencers who have no credibility, but they start saying things that they shouldn't be saying and making people feel bad about some of the foods that they're eating. So one of my biggest tips for anyone that I ever talk to is to unfollow any social media red flag influencers or anyone that makes you feel bad, because our mental health, as Dr. Freeman mentioned, is very, very important. Anyway, like I said, ultimate goal, create healthy habits to carry into adulthood. And I'll end there. I want to thank, our CF community and all of the research participants in Strong and all of our past studies here at Emory and beyond. We really can't do any of this work without you. And then I have wonderful lab. Our Emory CF Center is wonderful. And then I have amazing collaborators like Dr. Freeman and folks within the CF Foundation. So I will end there.
All right. Thank you so much, Jessica, for that great overview. Now it's time for a Q&A, so let's have Steve join again. We have a few pre-event questions we can start with, so keep entering your questions. I see some in the Q&A section, and so we'll get to those as they start coming in. But I'll go ahead and start with one of the questions that was submitted before the event. Steve, does anything reduce the frequency and duration of pancreatitis flare-ups? I know I've actually had that myself.
Yeah, for pancreatitis flares, there's a couple things. Number one is actually staying extremely well hydrated. That can help, just like in the lungs with hypertonic saline, keep secretions thinner. Pancreatic fluid or secretions in a healthy person are always very concentrated, about to get thick and precipitate and plug up the pancreatic duct system. You add CF and it's even thicker, more likely to precipitate out. So the more you can stay hydrated, that alone can help prevent flares of pancreatitis. Salt gets a bad rap. I think unless you have uncontrolled high blood pressure, heart failure, or your doctor says differently, salt plus fluids that you take in your diet is actually a good thing here to help prevent flares. The other thing is that, and this is literature back in the late 1970s by Dr. Phil Toscas, showed in people, these people did not have CF, in people who got recurrent pancreatitis, if you put them on a certain pancreatic enzyme called Viocase, I have nothing to do with this company, put them on Viocase, 3 tablets, first bite of each main meal, that would help minimize stimulating the pancreas and potentially triggering a bout of pancreatitis. Bottom line is chat with your local GI person about that.
Okay. Very interesting. I've got another question here, I think for maybe Jessica. Um, can you provide information on how best to gain weight and absorb nutrients? It seems there's a lot of confusion out there around dairy products, mucus production, and fat versus carbohydrates, and how to create the best balance.
Yeah. Okay. How to gain? Can you guys hear me?
Yeah.
I'll start with how to gain weight. Obviously, continuing to talk to your CF care providers and registered dietitians for needs specific to you. I do believe milk is an excellent source of protein and fats. The belief that it is not good for mucus production. It's a very common belief because milk is so creamy in the texture. It feels like it's coating your mouth and throat. But the good news is this really is it's a myth. It's been studied pretty thoroughly over the last many years with no impact on respiratory symptoms or other outcomes. So if you can tolerate milk, it still remains an excellent source of protein for other nutrients and other nutrients. Again, if you can tolerate it, everyone's different.
Here's a question from the chat. Is it hard to adjust to a low sugar diet after a childhood of being told to eat as much sweets as I wanted? How do you feel about artificial sweeteners?
Yeah. So, we're starting to deal with a lot of things, like I said, that we would never imagine we'd be dealing with. And so I think we can learn a lot from the non-CF obesity literature and ways that I agree with you. It is really difficult to switch your mind frame, especially after years and years of saying you can eat anything to like, no, whoa, stop, because you are already trained to do that. I think it will take counseling and working with a dietitian, maybe other nutrition health counselors, to start reframing your mind for eating a little bit more healthy than you have been before. Artificial sweeteners, I have no problem with them. I do know they get another bad rap. A lot of influencers will tell you that, but if the goal is to reduce added sugars, then maybe that's something that you can think about.
Okay, wonderful. That's, I know, helpful for me as someone with diabetes. Here's another question from chat. What is the relationship between CF and dumping syndrome?
Yeah, I guess that's to me. I mean, you can sometimes see that. Studies that have been done by other groups have shown that 1/3 of people with CF have normal emptying from the stomach. 1/3 have this paralysis of the stomach that I mentioned, gastroparesis, where there's very slow emptying, very delayed emptying. Everything sits in the stomach. And for some reason, a third of individuals, the remaining third, they have accelerated emptying. They dump. So basically, whatever's in the stomach is just going through too quickly in the intestine. That can cause diarrhea, can cause bloating, can cause abdominal pain. And sometimes we'll give certain medications just to slow things down. So that's kind of the relationship. Again, I think it's chatting with your GI doctor. Also, I'll make the plug of chatting with your registered dietitian, because diet can affect emptying from the stomach. And one thing I don't think, Jessica, you showed, I think at one point I saw this from you a number of years ago, how much sugar a person with CF consumes. It's incredible. And I can tell you, just in the general population, people would tell me, "Oh, well, I'm eating healthy. I'm having vanilla flavored Greek yogurt." And I'm like, "Do you know how much that flavoring adds in sugar? It's enormous. If you start looking at the labels, it's enormous." So I don't know if
Yeah.
Jessica, if you have
There
other comments.
no, there are so many added sugars, and this, like what I was saying, this obesogenic environment that we live in, um, it is really hard to avoid, but learning how to read labels, being wary of the word added sugars on the labels, because it is a law that they have to put that on there, is a good clue for you, or for folks to, if you're really thinking about reducing your added sugar intake.
Kind of to follow up on that, when you want to try to find a good GI doctor, is there a list of digest doctors?
If so, there are at every CF care center. They would potentially have a list. We're not in every center. We'd like to be ultimately. We're not. We're at quite a few centers around the country. With the CF Foundation, Dr. Whitney Brown, we've launched this visiting professorship series where now CF centers that don't have a digest GI person can reach out through the CF Foundation, and we're now basically virtually sending out one of our digest GI physicians, pediatric or adult person, to give talks and to be a resource to that center.
Okay. Also, one of the questions here is the SIBO breath test reliable?
No. That was an easy one. So they're not reliable if you have lung disease because we look at exhaled hydrogen in your breath. So if you have lung disease in CF, even mild lung disease, that would affect it. But even in the just normal healthy population, i.e., does not have CF, that the breath test is very unreliable. It's 30% positive at most in people that have small intestinal bacterial overgrowth, just in the general population. Uh, and so 70% of people have a normal breath test and they still have the small intestinal bacterial overgrowth. So we'll just clinically decide if we should treat with a medication like rifaximin. And if that makes you better, great. There's some other antibiotics we may use if your insurance doesn't cover it. Things like metronidazole, which is Flagyl, or a doxycycline, which is a tetracycline.
Okay, one other question in the chat is, are there standards for CF patients to be tested for other GI problems?
Unfortunately, not. I think pulmonologists have done an amazing job over all these years of managing all aspects of an individual with CF as the MD, along with their registered dietitian, mental health workers, and maybe other individuals. But the GI issues are a major problem. And I think we've learned that, you know, it was always thought, and I've asked this a lot to my patients. I'm like, how come no one's treated your GI issues? And the response would always be, we always thought living with CF is living with these GI problems, and it doesn't have to be anymore. And with dietitians and folks like Jessica, and with our digest group, and making pulmonologists and others on the team more involved, I think that has helped a lot. Most of us who are in digest or GI physicians with CF knowledge, we work closely with our dietitians. So, for example, on my side, I go in with my dietitian to see the patient, and dietitians on their own have done an amazing job in managing a lot of these GI issues. But I think it's just working together. This partnership is the ideal way to, I think, to address these GI problems.
Following another great question, I think, from the chat, if CFTR modulators are not impacting digestion as much as lung function, why are individuals with CF gaining so much weight now?
I can take that one. The CFTR modulators do seem to have some impact on, well, the inflammation. So number one, when you are highly inflamed and you're it's hard to breathe, which the CFTR modulators have been helpful. Your energy expenditure, you're just burning calories rampantly, just trying to breathe. So that has been calmed down a lot. So you're not burning as much calories just sitting there, just breathing. And then part of another thing was that inflammation across the board has been reduced with CFTR modulators. And there has been the malabsorption part has not been completely fixed, but there have been some reports and easing of the fat malabsorption there.
Another question from chat: how do you measure visceral fat around organs? This person says they're not familiar that this testing has been discussed at any CF clinic visit.
Yeah, that's a great question. So right now we are just doing it. We're doing it for research only. We use DEXA scans, so we can use DEXA scans to see it. It's not used clinically, but a lot of times what you might see doctors do or dietitians is just do a waist circumference measure, pull out the old-fashioned measuring tape and measure waist circumference. Sometimes even that, though, is not enough to see the fat that surrounds the organs. One of my studies right now is using MRI scans, which MRI scans are very expensive. We're not going to use those clinically to look at visceral fat. But those are ways, just research methods that we can look at. But yeah, it's really difficult to look at somebody and say, oh, they've got a lot of visceral fat. If unless they have the waist circumference area is very large.
So another question, we're getting great ones. Do you recommend taking an omega-3 supplement if you don't eat fish? In particular, this person says, I have a 6-year-old with CF worried about the risk of diabetes.
Well, I am a fan of omega-3 supplementation. If you don't eat fish, as Dr. Freeman mentioned, it is just a great source of DHA and EPA, these really healthy fats. So I am, but again, this is talk to your doctor. Everybody has different recommendations. And then as far as a 6-year-old with CF worried about the risk of diabetes, that to me is something that just kind of thinking about one of my last slides is starting to build healthy habits for children and starting to really emphasize eating healthy foods and getting strong and, eating foods that will make my body strong and grow healthy. And that is fruits and vegetables, lean meats. So yeah, I think as for a 6-year-old, someone who doesn't have impaired glucose tolerance or anything like that, these are things that you can start thinking about and doing now. Introducing, just again, start trying to build these lifelong habits that don't happen overnight, obviously, because even I am not perfect. No one's perfect, and I'm still working on my own habits.
Yeah, maybe I'll just jump in for a moment, if I may. Omega-3. This is my life. So I would augment or enhance what Jessica says. I think number one is eating healthy. People think if you just pop a couple of fish oil capsules, that can override eating McDonald's hamburgers and French fries and whatever. So your body is very clever. And if you take in a lot of omega-6 fats, so that's like red meat, fast food, things fried in vegetable oils, no omega-3 amounts going to override that. So it's this balance between omega-6 fats in the diet and the good omega-3 fats. If you're eating relatively healthy, can you increase your levels even further? These omega-3 fats, then yes, maybe supplement on top of it may do it. This is something we're in a research mode studying currently right now, and whether or not levels predict risk of disease and cancer, and whether or not we can increase levels a lot more, and would that have an effect on decreasing that increased cancer risk in CF. That's what we'll be sorting out over the next 2 years or so.
Yeah, I agree with Dr. Freeman. Bottom line is build a foundation of healthy diet, whole foods, less so than depending on supplements.
Agreed.
So you kind of just mentioned this, but do people with pancreatitis issues have higher chances of pancreatic cancer?
Good question. We know in the general population, non-CF, that there is a very slight increased risk of pancreatic cancer in people with chronic pancreatitis, chronic inflammation of the pancreas. Not so clear in CF. We haven't seen that yet. So probably not a big risk, at least for the moment.
So following that, I think one of the questions we had in advance was, what advances have been made to better understand the pancreas? And how do these advances benefit the whole CF community?
Yeah. So on the exocrine side of the pancreas, pancreatitis, pancreatic cancer, we're still in its infancy stage, but we're understanding a lot more about uh, what drives inflammation of the pancreas, but especially what drives cancer of the pancreas. A lot of groups around the world have been studying this. We potentially have, I think, and again, we'll just have to see how this plays out. But our preliminary data and through philanthropy and National Institute of Health, we're getting some very exciting data on why there's an increased risk of these cancers in the setting of CF, at least using our mouse models. And so I think we're all working very hard on this. I think in the next year we may see some exciting results and advances here. Can't tell you for sure, but we think there will be, and it's related to this whole way that the body normally prevents cancers from forming.
Well, it's good to know we're still doing some research on all these great topics tonight. I think we'll have to wrap that up now. And I want to thank our presenters, thank everyone for participating, and great questions. Before we go, please fill out the satisfaction poll, which is under the poll tab on the right-hand side of your screen, right next to the session chat. There are many wonderful resources related to this discussion, including the slides from today, in the resource document found on the reception page. Please spend some time exploring the resources and downloading anything that you want to keep. The presenter emails are in the chat, so feel free to email any questions that we didn't get to today. Thank you.